we've seen is that we have very significant benefits from the use in certain patients and for certain tumors, certainly. And there's always been a concern that there is an under reimbursement for SRT. And the American Cutaneous Oncology Society has been fighting very hard for the last few years with CMS. And this year we were very happily surprised that they've listened to us. There's a 76% increase in reimbursement for the main code that we use for radiation therapy, which is 77401. So that's very significant. And we've had for the last few years the ability, and in fact, they've said we should be using E&M codes. And the reason we use E&M codes is that the 77401 includes nothing when it comes to evaluating either the history of the patient nor the lesion itself to determine whether or not we should continue radiation therapy. What we do for each treatment is have a history, whether the patient is having any problems, pain, irritation, etc. What have they been putting on anything? Have they been compliant? And then we do an examination to look for things such as ulceration, radiation dermatitis, and there are different forms of radiation dermatitis, obviously, in the acute phase, different levels, and then make a determination from there of whether or not we're going to treat on that day and future days or hold off of radiation therapy. And based on the new guidelines with evaluation and management codes, early on, if there is erythema or an ulceration, that's considered an acute illness from that perspective, and you'll make a determination, and that would equate to a 99213. And then as patients develop radiation dermatitis, and radiation dermatitis clearly in looking at the skin is very different than radiation dermatitis if you're treating something such as breast cancer, where it's really just a side effect. The radiation dermatitis is being concentrated in and around the tumor, and it's important because we utilize this as a proxy of whether or not we'll continue treatment. So radiation dermatitis is a chronic dermatitis. It has an acute phase, but it always has a chronic phase. And what we're doing in terms of the ultimate benefit to the patient is we're trying to limit the long-term consequences, that being the chronic phase, as much as possible. And that's this therapeutic index. So what we're doing is we're having an exacerbation of a chronic dermatitis, in this case radiation dermatitis, and we're making a determination of whether or not we're going to do radiation treatment, which is akin to making a determination of minor surgery. It has nothing to do with the tumor. It has to do with the surrounding areas of radiation, dermatitis in this case. And in doing that, that would equate to a 99214. And I think that, what has been very clear is that, the determination that we have has to do with the degree of radiation dermatitis in the area, perhaps the degree of ulceration of the area, whether it's what grade, and we have to decide whether or not to do treatment or to hold off on that day. And that's really where the specific documentation is for 99214. Absolutely, because we have to evaluate the patient on every visit. Now, early on, we may not see radiation dermatitis, and it just may be, erythema in the area. It just may be making sure the patient is having no acute problems from this. So it will be a lower visit code, maybe a 99213. But for each time you're taking a history, is the patient doing okay? Are they having any issues? We're evaluating the lesion and the area itself and making that determination.